Hi everyone. For this lecture, we're going to talk about dyslipidemias, or basically problems with your cholesterol. Remember that this is a narrated lecture, so if you're hearing this already, then you followed the directions perfectly. Fantastic. Here are the objectives of our dyslipidemia lecture. Um, Obviously, we're going to talk about the definition of dyslipidemia, what's considered good, what's considered bad, and then our etiology, risk factors, complications, and epidemiology. And you notice here, we're going to talk about the lipid metabolism, but we're also going to talk about two basic categories of dyslipidemias, and that's primary and secondary dyslipidemias. Just at the top of the lecture here, I want to let you guys know that it's interesting because secondary dyslipidemias tend to be, those are the ones that we consider as problems with our eating habits and other modifiable risk factors. Whereas primary dyslipidemias tend to be problems that are genetic problems or issues that can actually cause really, really, I guess, high levels of triglycerides and LDLs and things like that. So they're the ones that are more familial. And then we'll talk about the screening process and diagnosis of dyslipidemias and then the basics of management. So first off, what is dyslipidemia? Well, it's either an elevation or decrease in your cholesterol or triglycerides. Generally, it's an elevation of total cholesterol or an elevation of your low-density lipoproteins or LDLs, and it's a decrease in your high-density lipoproteins or HDL. So those are the general things that we say as bad, cholesterol. Sure, the term dyslipidemia just refers to a change from normal, but I think just from general knowledge, you guys understand that these are the basic trends that we don't like. When we use the term fats, we mean triglycerides and cholesterol. Now I want to go over this too, right? When we talk about cholesterol, the molecule, versus when someone says my cholesterol is bad. So yes, of course, cholesterol itself is specific as a molecule, so as a sterol molecule. Whereas cholesterol as that term, it's when we talk about a whole set of things. So we're talking about LDLs, HDLs, and triglycerides. So here it is as the actual molecule, right? It's a sterol group with a hydroxy group and a hydrocarbon tail, and it makes up steroid hormones like estrogen and testosterone and cell wall membrane components. So, right, we always say this, your body needs cholesterol. It's not like you can't have cholesterol, but this is the molecule that we talk about when we say cholesterol. So in contrast to cholesterol, the molecule, when we talk about a lipid panel or a cholesterol panel, then we're really talking about lipid proteins. So slightly different, right? Combinations of things, lipids plus proteins, and also triglycerides. So here you can see our general charts of total cholesterol. We prefer less than 200 milligrams per deciliter. For HDLs, we want greater than 60 milligrams per deciliter. For LDLs, we want 100 to 129 milligrams per deciliter, and then triglycerides, looking for less than 150 milligrams per deciliter. So LDLs, whenever you look at a cholesterol panel, are generally calculated. You can see that the LDLs equal the total cholesterol minus the HDLs, and then we have this conversion factors of triglycerides divided by 5 if you're using milligrams per deciliter, or your triglycerides divided by 2.2 if you're using millimolar per liter. And we'll see this actual calculation on the next slide, but basically what we're saying is that the total cholesterol equals all these different types of lipid proteins. The high density ones, the low density ones, the very low density ones, and then the intermediate density, which we'll see on the next slide. So first, can you always calculate the LDLs? generally, unless the triglycerides are greater than 500 milligrams per deciliter, then your calculated LDLs are inaccurate, and in that point you have to order a specific LDL serum measurement, which is a fasting test. So part of that reason, again, goes back to the fact that when we talk about total cholesterol, we're talking about a bunch of different lipid proteins, right? So LDLs plus HDLs plus VLDLs and other lipid proteins, things like IDLs. Because your triglycerides, they vary a lot with your diet and can fluctuate pretty rapidly. HDLs and LDLs don't tend to move based on your diet, but your triglycerides do. So if you've had a really, really fatty, greasy meal, then they can throw off the calculations of the VLDL. So that's why if triglycerides are really high, then your LDLs might be considered inaccurate, because the VLD or the triglycerides kind of take place of the VLDL component. Okay, does that make sense? Basically, since the VLDLs are calculated as the triglycerides, or at least they're estimated by their triglyceride level, and the triglyceride levels vary widely depending on, or they can be affected by a really high fat meal, it can be inaccurate to calculate the LDLs when that happens. So what is the triglyceride component of our cholesterol panel? Right, it's the glycerol backbone plus the 3 fatty acids. It's a big part of the energy storage in our adipose cells. It's a component of our cell membranes. Again, I just said it's a big part that responds to diet and exercise more readily than just our regular cholesterol lipid proteins. And again, it's when you have a non-fasting sample that it really can underestimate your LDL levels. So sure, your triglyceride levels can be really increased from meals and things like that, but a lot of times it happens in our secondary dyslipidemias too. So if you have a patient that has some sort of familial dyslipidemia that causes high triglycerides, then those patients really need fasting levels of, to make sure they have fasting levels of their cholesterol to avoid this under estimation of LDL, which is, it's really important, especially in those patients with the secondary dyslipidemias. The other categorization we use of triglyceride is to talk about them as saturated fats or unsaturated oils. It refers to the types of triglycerides that are found in these things, and it's related to the number of double bonds found in the fatty acid chain. So those 3 fatty acid chains you can see here on the right. On the top molecule, you can see that those are polyunsaturated fats. And those have double bonds in the chain, which cause kinks, right? When you have a double bond in those, remember back to organic chemistry, it causes those not to be able to rotate around those bonds there. And so they create these kinks, and these things take up more space, right? When you have saturated fats, if you look at the lower triglyceride, well, then those tend to stack up really nicely, and so you get them to be a lot more dense, which causes a change in the melting point. So if you have a saturated fat that has no double bonds in it and all of these triglycerides can pack really densely together, well, then those things tend to be solids at room temperature, versus unsaturated fats, they tend to be liquids. They tend to be unsaturated oils. This burger here probably looks alarming and delicious. For those of you that are from Terre Haute, you can probably tell that these are square donuts. And so this is an actual burger that you can order at a restaurant called Fifi's. And you know, when they made these, they didn't. Yeah. Let me start this way. If someone told me to make a hamburger with a donut as the buns, I'd assume that I would make it by cutting the donut in half. But if you think about it, you'd be missing an entire donut compared to what's going on here. So obviously this is the correct choice. So yeah, you can get these at Fifi's. You can also get them without bacon or cheese, but then at that point, why? Why? So some examples of the triglycerides to really look at saturated versus unsaturated. Saturated fats tend to be red meat, all that marbling, all that delicious marbling you see in red meat, lard and butter, right? Those are solids at room temperature. Versus unsaturated fats tend to be oils. So avocados, they have definitely a creamier texture. Olive oil, nut oil, vegetable oils, those tend to be unsaturated fats. When we talk about unsaturated fats, we can also talk about the types of double bonds that you see within them. So in nature, the double bonds tend to be cis double bonds, which really causes that kink. So cis, you can see there with the two reds where the chain continues along on the same side of that double bond. Whereas trans double bonds means that the link crosses from one end to the other end of that double bond, which again tends to be a little bit more linear. So that doesn't happen all the time in nature. That tends to happen with processing of fats. So the processing causes no kinks, decreases the steric hindrance of these molecules, which allows them to be less solid. Okay. Partially hydrogenated means taking an unsaturated plant oil and hydrogenating it. So removing the double bonds and reproducing bonds that tend to be trans bonds. So that's the partially hydrogenated trans fat triglycerides. I have a picture here of this buttery topping. I probably haven't told you guys this. Maybe I did in another lecture. One of my first jobs out of high school was at a movie theater, and like people have come up with amazing ways of making sure that the buttery topping gets on all of their popcorn. And I haven't seen this about sticking a straw in it and putting it all the way down. I mean, that's one way to do it. But the thing that kind of scared me about this buttery topping stuff is that when we would clean the machines out, we would have to use like steel pipe cleaners to scrape literally it turned into rubber. And it just imagine kind of like, wow, what would that do to your arteries and stuff? But who knows? Maybe it lubricates your arteries and makes them better. That's what I'm going with. So with triglycerides, traditional thoughts, right? Unsaturated fats tend to be associated with decreased LDLs, right? They tend to be more liquid. They tend to be less solid. So those are the ones that are associated with decreased LDLs, whereas saturated fats and then trans unsaturated fats are associated with increased LDLs. That's a traditional thinking, but as some of the studies are showing that this may not be, that there may be more truth to some of these things. So here's a link, you can take a look at that. Okay, I know you guys probably talked about this already in physiology, but I just want to cover it again as it pertains to the medications that we're going to be talking about, and specifically the different types of secondary dyslipidemia. So problems that occur with this that end up causing secondary or genetic dyslipidemias. Okay. So dietary fat is ingested. We eat a real big, good steak, and bile salts, which are dispensed by the liver, help to solubilize those things, and then our enterocytes uptake these fats. They're converted into or digested into cholesterol and triglycerides, which are then packaged into lipoproteins. Right, so these lipoproteins are the different things like LDLs, HDLs, those are the things that are measured. That's why we want to make the distinction between actually measuring molecules of cholesterol versus what we're measuring is the packaging of them. So that really, we're measuring the amounts of packaging, and we measure the total cholesterol when we're doing a cholesterol panel. And what are the different types of lipoproteins? The first lipoproteins, this is kind of a stepwise process here that you can see. Once we've ingested fats and the enterocytes take them up, they repackage things into chylomicrons. Okay, if you look here, there's really three main components of these different lipoproteins: lipids, proteins. Okay, so the ratio of these things, and the different lipids are cholesterols and triglycerides, but the different ratios refer to how many what's the protein to the cholesterol and triglycerides. So what's the protein ratio to the lipid ratio? You can just look and see that in the chylomicrons, the ratio is very low. So very little protein compared to how many lipids there are. So the yellow is going to be mainly your lipid component. When you have VLDLs, you have very low density lipoproteins. So again, a high amount of lipid versus the lipoproteins. And then you travel on as you're removing the lipid content, you're getting higher lipoprotein ratios, right? So I hope that makes sense. And when I say stepwise, like I said, the first things that are kind of produced are these chylomicrons, and then generally, as the lipid content is removed from these lipoproteins and used as in the body, the ratio of proteins increases, right? So less and less lipids as we go through there. And that's why at the very end we have high density lipoprotein, which has very little lipid content and has high protein content. And the hope is that if you can increase your HDL content, that these good cholesterol molecules tend to reabsorb and take LDLs back to the liver. So they're actually a component of removing lipids from tissues and the bloodstream by HDLs. Here's just another representation of these lipoprotein density ratios. So again, chylomicrons, you can see they have a lot of triglycerides. Okay, sure, there's some phospholipids on there, right? Those are the components of the membrane, but the other big component is the cholesterol, right? So the red and the blue compared to the kind of beigeish color. So as you go through, you can see the amount of triglycerides kind of decrease. Phospholipids aren't going to change that much. Okay, they'll change, but they won't change that much, right? Just the membrane component. But also the cholesterol kind of goes up and down, but in general it tends to decrease as we go from chylomicrons to the HDLs. So that first step, like I said, we ingest, we solubilize, and then our cholesterol and triglycerides are packaged into lipoproteins. The enterocytes then package them into these chylomicrons, which again have a very low amount of protein versus the lipid content. So here are the chylomicrons, and from the chylomicrons, they get travel into the blood, and they deliver triglycerides and cholesterol to tissues. Okay, so now we have a large, you can see the difference between the chylomicrons, which then deliver the lipids, which then lose them, and then we get remnant chylomicrons and cholesterol, which get transferred into the liver. So this component here delivers a majority of triglycerides, but retain the cholesterol. Okay, you can see the cholesterol component on this graph is orange, doesn't really change much, but the triglyceride level does. This is a big reason why if you have a big meal, all these chylomicrons are just converted right away, and you may have a high level of chylomicrons, which will make up the problem with your LDL measurement, because again, it's really based on diet and exercise, and can change rapidly. Another big important thing to talk about on this slide, or at least this part of it, is that in order to deliver triglycerides to the tissues, a protein called lipoprotein lipase is required. So it helps process the triglycerides and cholesterol from chylomicrons and the VLDLs, the other big lipoprotein that has a very low density. So LPLs process triglycerides from the chylomicrons and help transfer triglycerides to the tissue so they can be processed. So you can see on this chart here, they get processed into glycerol. They get to use towards glucose synthesis, and they basically we require LPLs in order to process triglycerides. You can see there, without LPLs, triglycerides collect in the serum, which is bad. The liver produces, once it gets these chylomicron remnants, it injects some triglycerides and cholesterol back into these and then produces VLDLs, our other low density or very low density lipoprotein. Okay. VLDLs then give triglycerides and cholesterol to adipose cells and other tissues, which again, as we're decreasing the amount of lipids there, they tend to become the intermediate density lipoproteins and low density lipoproteins. The liver also produces HDLs, which gathers triglycerides and cholesterol and delivers them back to the liver, or they are converted to steroid hormones. So again, that's why HDLs tend to be good. So they tend to, clear up extra things and even pull things out of tissues and the serum. Okay, so that's why when we're looking at a cholesterol panel, it's an increase in HDL, which is what helps. So here I just want to talk about the basics of the cholesterol lowering drugs. Obviously, you're going to cover this in pharmacology and go into a lot more detail and things like that. But obviously, I want to just bring up these things so we can talk about the basics of their mechanisms as we continue to talk about the pathology of dyslipidemia. So first off, the main category that I want you guys to know about, or that you already know about, are statins. Okay, under the use categories here, you can see the main thing that we are concerned with is the LDL lowering aspects of statins. The mechanism is that it is an HMG-CoA reductase inhibitor, which means that it reduces the amount of cholesterol produced in the liver, right? HMG-CoA reductase is important in converting HMG-CoA into cholesterol. So with the reduced production in the liver, that means that it is able to send less of it out into the serum. If there's a reduced amount of cholesterol in the serum, that obviously that reduces the serum cholesterol levels, but it also increases the LDL receptors on the endothelial cells. And if you have increased LDL receptors there, that means that you are taking up more of the cholesterol or more of the LDLs that are found there. Again, taking it out of the serum. So decreased LDL levels. The problems with these drugs is they tend to have myopathy or muscle pain associated with them, and they can cause a little bit of liver damage. So you always want to check for liver enzymes when you have patients on this, and just monitor their if they're having any muscle pain. That tends to be the most common reason people can't take these drugs. The next category are the fibrates, and they tend to focus on triglyceride lowering. Lots of different mechanisms of these, but they tend to act on the LDL receptor activity and concentration of those LDLs, which helps to take more triglycerides out of the blood. Again, you can see for side effects, there's myopathy involved and gallstones. So kind of the problem here is, these are two really good medications, fibrates and statins. And you'd think, well, gosh, why don't they just have combinations of these drugs, put them together? Well, unfortunately, it causes lots of myopathy, and it can even lead to rhabdomyolysis, which is a big problem. Again, I know you guys cover that in pharm specifically. But there are some combinations. You tend to see fenofibrate, which is Tricor, and simvastatin tend to be, for people that have severe problems, tend to be used together. That there's a less of a risk of rhabdomyolysis. It's still there, but there's a lot of studies showing that that's depending on the severity of the dyslipidemia that you're dealing with, that might be a good option. For niacin, these tend to be HDL increasing. This is an HDL increasing medication. It increases ApoA1, which is the HDL containing protein components of lipoproteins. The side effects for these is that you get that flushing sensation. What I have in here is that we use aspirin to treat that. So patients that can explain about like this hot, redness in their face, it's not necessarily an allergic reaction to the medication. I mean, it's a side effect. It's flushing, and you tend to use aspirin to get rid of that. There's also a lot of headache and dizziness associated with this too. The next class are the bile resins, and these tend to lower HDLs, but there's also a slight increase, there's a risk for a slight increasing of triglycerides. And the way that they work is they tend to bind to bile acids and reduce the reuptake of them. So for those of us that are old enough to remember the Olestra chips that Lay's put out, this is similar to what it is. It used to bind up the fat so you wouldn't get them into the enterocytes, that wouldn't be taken up. The problem with that is that then they would travel into the colon and basically cause abdominal discomfort because of gas. So it's a very similar thing as lactose intolerance, where if your body doesn't take up lactose, it then gets into the colon, and then those microbes act on it and produce gas. So that's kind of the problem with these types of medications. And there's ezetimibe, or Zetia. This is another LDL lowering drug. It tends to be used in adjunct with statins, but it helps to reduce cholesterol intestinal absorption again, okay? Similar to the cholestyramine, but instead of abdominal discomfort, patients tend to complain of diarrhea with this one. So these are the general classes of cholesterol lowering drugs. Again, I just wanted to cover them really briefly because we'll talk about some of these mechanisms as we move on. So let's talk about the pathology of atherosclerosis. The reason that I bring up such a simple slide like this is I think a lot of these terms are thrown around and we forget kind of the progression of one of these terms into another. Which one of these are risk factors, which of these are pathologies, which of these are actual disease process. So put simply, the reason dyslipidemia is bad, the problem with having all these high LDLs and low HDLs in our blood, is because it's one of the major causes of atherosclerosis, okay? Atherosclerosis being plaque formation in our vessels. And I kind of mentioned this when we talked about our acute coronary syndromes, right? When we're talking about acute coronary syndromes, it's specifically atherosclerosis in the coronary vessels, which causes ischemia to the heart. And again, I briefly mentioned that there's a lot, even though the main thing that we talk about that causes atherosclerosis is dyslipidemia, there's other risk factors or other contributing factors to atherosclerosis. So over this next section, I'm going to talk about the basics of all the different pathologies of these and how they cause atherosclerosis. But I really want to focus on dyslipidemia. The other ones, I just want to show you the connection so that you can pass this on to your patients. Sometimes it's difficult to understand, well, why does smoking increase your chance for heart attack? Right? Why does diabetes increase your chance for heart attack? We always know these as risk factors, but what's the actual pathology behind it? So for general atherosclerosis, let's just talk about this timeline, right? So we know that lipoproteins, doesn't matter if they're LDLs or VLDLs, they travel in the bloodstream to deliver, and if they're HDLs, pick up triglycerides and cholesterol. Right now, let's talk about about LDLs, since those are the ones that tend to cause the most issue, or at least those are the most classically described. So in this very classic chart here, we see the steps, okay? We see the steps from the production of foam cells, which we'll talk about on the next couple slides, the formation of a fatty streak, and then we have an intermediate lesion and then an atheroma, and you can start seeing with an atheroma, you get a lot of lipid buildup in the endothelial layers or beyond the endothelial layers of a vessel. Then we get the formation of a fibrous plaque, and then complications, we get a lesion and then a rupture of this plaque, which can cause lots of different problems. Along the bottom of this, we have the big word here, endothelial dysfunction. And this is the big connector between all the different types of risk factors for atherosclerosis, is that we start with endothelial dysfunction. So anytime we talk about that term, we're talking about this process of foam cells, fatty streaks, and intermediate lesions. Doesn't matter if it's diabetes, doesn't matter if it's dyslipidemia, it's going to cause endothelial dysfunction, which causes this process, okay? So when there is no endothelial damage, though, LDL particles pass through the endothelial cells via transcytosis, okay? So as long as they go through this receptor-mediated process through the LDL receptors, the cholesterol and triglycerides are processed in an orderly way. The problem is when you don't get through this transcytosis, if they're not endocytosed and they're not moved into that layer correctly, that's when we get LDL particles passing into the vessel wall, okay, bypassing transcytosis, and then they're kind of seen as foreign molecules. So we have monocytes that are activated into macrophages, and the macrophages take up these LDLs, and now they get converted into foam cells. So that's all foam cells are macrophages that are full of LDLs, okay? Once we have the uptake of LDL by actual smooth muscle tissue because of increased inflammation and they're just sitting there, that's called a fatty streak. So when compared to our previous slide of the formation of foam cells and fatty smooth muscles and fatty streaks, it really is just LDLs sitting in there. They're taken up by macrophages, and they're just sitting there so long because macrophages can't do anything with them. Now they're starting to get incorporated into the actual smooth muscles of the vascular wall. So how does dyslipidemia cause this endothelial damage? Well, that's more related to age, okay? Just the natural recycling of the endothelium and the high level of LDLs in dyslipidemia causes that buildup of LDLs. It's just not able to process it enough, and like I said, the more LDLs you have in the bloodstream, the more likely they are to bypass this transcytosis and just end up in the wall and not be processed. What about for diabetes? I don't want you to memorize these. So for the next few slides, you're going to see a bunch of difficult and complicated processes. I'm not going to ask you questions on any of these diagrams. I just want you to know for your own sake that, yeah, increased glucose levels causes a lot of different things that end up causing endothelial dysfunction. You can see that on the far left there, the mechanism is something called glycation, and it's basically what's going to happen when the endothelial cells, they tend to get glycosylated by all the extra glucose that's in the blood, which causes damage in between the cells, which causes the bypassing of transcytosis. And again, you start to get buildup of LDL within the wall, which is endothelial dysfunction. For smoking, again, very complicated chart here with a bunch of different mechanisms, but the end product is that because of all these things that are happening, you're going to end up with endothelial dysfunction. You can see there on the far right side, increased fatty acid production, decreased ENOS downregulation, and decreased generation and bioavailability of nitrous oxide. That's all that downregulation means. Hypertension, a bunch of different pathways again, but they lead to this bypassing of transcytosis, which leads to endothelial dysfunction, producing foam cells, fatty streak, and then plaque formation. So all of these things lead to atherosclerosis. And of course, just to kind of wrap things up here, as far as this, closing the loop on this, things that cause endothelial dysfunction, that's the process of atherosclerosis. We get plaque formation. If it's in the coronary artery vessels, well, then that causes angina and acute coronary syndromes. These other diseases you're going to talk about later, carotid artery disease and peripheral artery disease, you'll talk about with Nicole. And then chronic kidney disease we'll talk in the fall later. So obviously the big complications of atherosclerosis.